Good morning, good afternoon, and good evening. Thank you for joining JICA COVID-19 webinar. Before starting, let me inform housekeeping announcement briefly. Today, this webinar is being held in English and Japanese. An interpretation function is available on the interpretation button. So please select the language of your choice to enjoy the discussion. Q&A session. Please do not hesitate to ask questions to the speakers through the Q&A functions. We'd like to have a discussion time as much as possible, so we'd be delighted to have your comments and questions during and after the speaker's presentation. Please remember using Q&A function for writing questions, not using chat box. We are going to record today's webinar and upload a video on the YouTube channel of JICA Ogata Research Institute later. We have uploaded the speaker's presentation slide in the cloud for your reference. You can find access information in the reminder email we sent 1 hour ago, as well as the chat box. Please kindly be reminded that reproduction or any part of the contents is prohibited. Let's move to the session. I'm Saida Makimoto of JICA Ogata Research Institute, MC of the webinar. At first, I would like to share the purpose of the webinar. We titled today's webinar as Building Health System Towards Resilient Universal Health Coverage with and after the pandemic. We are in the COVID pandemic nearly 2 years. During these 2 years, to respond to the COVID-19 and sustain other health services at the same time, countries have making effort to rapidly increase and reorganize health service delivery capacity. Some countries may have had a legal framework or policy tool to enable such rapid increase, and others may have taken other approaches to deliver the services. For example, the partnership with stakeholders or using digital technologies under the resource-limited situation. As an impact, the COVID-19 and non-COVID-19, we are experiencing excess mortality showing in the map, as shown in the map. In the future, we would like to minimize this kind of excess mortality. And for that, we have to learn the experience from each country is experiencing right now. So in this webinar, we will listen different countries' experience and lessons of preparedness adaptation of health service delivery to cope with COVID-19 and others, and discuss what implication this experience has for the effort to achieve resilient universal health coverage with and after the pandemic. In JICA's COVID-19 webinar, usually we focus on Japan's experience, but today we invite various experts from the world, as shown in this slide. First, I would like to invite Dr. Haruka Sakamoto, Associate Professor, Tokyo Women's Medical University, to share her research about G7 countries. Then we will move to each country's presentation: Japan, Kenya, Vietnam, and Thailand. And then we will have a discussion. So as I already said, please don't hesitate to put your comments or questions in Q&A functions. Okay. So I would like to invite Dr. Haruka Sakamoto Yes. Associate Professor, Tokyo Women's Medical University, sharing COVID-19 and healthcare system of G7 countries. The floor is yours.
Thank you very much, Makimoto-san. Hello, everyone. Can you hear my voice and see my presentation slide?
Yes.
Okay, thank you. Good evening, everyone. My name is Haruka Sakamoto from Tokyo Women's Medical University. Thank you very much for inviting me here today. So as Makimoto-san introduced, I'm currently conducting a survey on COVID-19 and then healthcare delivery system, especially in the G7 and then high-income countries. And then today, I'd like to talk about the outline of the survey and then what kind of lessons learned about healthcare delivery system during a pandemic from those countries. So this is the background of my research. Since the beginning of 2020, many countries around the world have seen a rapid increase in the number of COVID-19 patients. Even in countries that are considered to have solid healthcare delivery systems, such as G7 countries, their resources are still limited. And then how to treat COVID-19 patients with such limited medical resources while continuing to treat diseases other than COVID-19 has become a very important issue for each country. The healthcare delivery system is a huge concept, but one of the most important aspects, especially during the pandemic, was the reorganization of hospital beds, or in other words, securing hospital beds that can treat COVID-19 patients, and ensuring medical personnel who can engage in the treatment of COVID-19 patients. However, such reorganization of hospital beds and an allocation of human resources is largely related to the underlying healthcare delivery system of each country. Since healthcare delivery systems vary greatly from country to country, there was no uniform method of any kind for reorganizing hospital beds and then allocating human resources. And then each country responded in its own way. So in this study, we will investigate and summarize such cases of response in each country, and then provide insights not only on the response to COVID-19, which is still ongoing, but also on how to prepare for future pandemics. I'd like to talk briefly about the methodology of the survey. So in this survey, we used a questionnaire to examine how healthcare delivery systems were improved during the COVID-19 epidemic for the G7 and then high-income countries, such as South Korea, Taiwan, and then Australia. The survey consisted of about 40 items. The survey was conducted from the summer of this year to the present, and then each country was asked to describe its notable efforts from the beginning of the 2020 to the present, focusing on the period when the impact of the epidemic was the greatest in each country. As the survey is still ongoing and then not all the responses are yet available, the information presented here today should be taken only as the findings at the preliminary stage. In addition, even within a single country, the response may differ greatly among states. Due to time constraint, I will not go into the details of my study today, but I'd like you to keep this in mind as a limitation of this study. First, let's look at how many hospital beds each country has in normal times. Here's a breakdown of the number of hospital beds per 1,000 people in each country, as published by the OECD report. It is often said that Japan has outstandingly large number of hospital beds, and then one of the reasons for this is that it has a larger number of beds for chronic and then long-term care. But the point is that number of the bed per population is very different among the countries. On the other hand, this is the number of ICU beds per population and its number of medical personnel, such as physicians and then nurses. Again, the figures differ greatly from country to country. But if I'm focusing on Japan, for example, we can see that although the total number of hospital beds in Japan is much higher than in other countries, as seen in the previous slide, the number of ICU beds in Japan is lower than in other countries. Also, the number of physicians is also lower in Japan compared to other high-income countries. Given this background, I'd like to introduce some of the answers about what measures each country has actually taken, starting with the reorganization of hospital beds. As for the reorganization of hospital beds, the main resources conducted in the G7 and other high-income countries were to accept COVID-19 patients in beds that do not accept patients with infectious disease in normal times, and then to create temporary beds, and then to transfer patients other than COVID-19 to medical institutions that do not treat infectious diseases in the same area. By doing so, the medical institutions treating COVID-19 patients were able to reduce the burden of seeing non-infectious disease patients. This included requests to the private medical institutions, not just local primary and then secondary care hospitals. Next, I'd like to introduce about the measures taken to secure the human resources. These including the followings: introduction of the doctors from other departments or specialties, and then introduction of retired or currently on leave physicians, and then the dispatch of doctors from different prefectures, and then acceptance of doctors from overseas, and then also the introduction of medical students, and then in some countries also introducing task shifting, such as temporarily allowing other professions to perform medical procedures that were originally only allowed for the physicians. In addition, various supporting measures were taken for medical personnel in each country to enable this reallocation of human resources. For example, in Italy, a payment of 200 euros per day was made in addition to the basic salary in order to secure the adequate human resources. Also, advanced training opportunities were sometimes provided, especially for the physicians who had not previously specialized in intensive care to join their practice. In addition, the necessary legislation and then other measures were put in place to enable the above measures to be taken. In response to the exponential increase in infectious diseases such as COVID-19, many countries have had difficulties in securing hospital beds and human resources. But just as I have explained, each country has made various efforts. On the other hand, there are still issues regarding the reallocation of human resources. The first is an evaluation of the quality of medical care actually provided by the hastily prepared personnel, or to put it more directly, the outcome of the medical care provided by such a rapid increase in the medical staff has not yet been sufficiently evaluated in most of the countries. In addition, some countries have introduced medical staff and medical students from overseas, but where is the responsibility when an unfavorable event occurs? Such issues has not yet fully been discussed. In addition, during the crisis, many people are highly motivated to provide medical care. However, at some point, mental health problems will appear. So the mental health care system for these medical professionals was also pointed out as an issue in many countries. Finally, the following lessons were heard from various countries regarding the restructuring of the healthcare delivery system during the pandemic. First, it is of course necessary to be well prepared, including advanced planning. At the same time, it is important to be able to switch to crisis mode. In many countries, the initial cases in China were seen as on fire on the other side of the world. By the time they realized that the infection was spreading in their country, It had already spread it beyond their control. Also, the situation is not uniform within the country. For example, in the COVID-19, older population were at high risk, but the aging of the population varies from region to region. Also, the availability of medical resources vary from region to region. Thus, it is necessary to understand in advance who the vulnerable groups are in your country, where they are located, and then what the characteristics of each region are. It is also pointed out that the importance of governance, especially the importance of collaboration with these related stakeholders. This is not limited to the central and the local governments, but also includes the collaboration and then role sharing within the region or in the community, such as the collaboration between public and private sectors, or collaboration between the primary care facilities, the tertiary care facilities. In particular, there is no simple right answer for regional collaboration, and then it is necessary to build a collaboration system for each region based on the medical resources that each region has. Finally, there is a use of digital technology. The usefulness of digital technology has been pointed out for sometimes before the pandemic, but I think its importance has increased even more with the pandemic. I believe that digital technology will play a major role during the pandemic, from the rapid understanding and an analysis of epidemiological information to the use of the online medical services. So thank you very much. So this is the brief summary of what our research findings shows. And then after all the presentation finishes, I'm happy to take any question and comment. And then I'm also looking forward to the panel discussion. And then lastly, I deeply apologize that my baby is crying on my backside. I really apologize for that. Thank you very much.
So Dr. Haruka, thank you very much for sharing your research findings. And we don't care the baby is crying a bit. Your presentation was very comprehensive and cross country findings. Next, we would like to go into each country's experience. We would like to start from Japan's experience. Now, I'd like to invite Professor Koji Wada, Professor of Department of Public Health, School of Medicine, International University of Health and Welfare, Japan. He is the member of a national level team for COVID-19. Dr. Wada, can you appear?
Yes.
Okay. Yes. The floor is yours.
Okay. Thank you very much. Good evening. Konbanwa. I really appreciate all of you listeners to have time with us. My name is Koji Wada, working for International University of Health and Welfare. I'm a medical doctor and specializing in public health. And as Makimoto-san said, I have been committed to the advisory board for the Ministry of Health, Labor, Welfare in Japan since 2019, after the COVID-19 emerges. So the COVID-19 pandemic has had a variety of negative impacts on our lives. And in almost 2 years, globally, it has been reported that almost 260 million people have been infected by the COVID-19 and 5 million people have died in the world. And this has been a kind of a stress test for our healthcare systems. In this presentation, I would like to talk about our challenges in Japan to responding to the surge of infected patients. And actually, there have been many lessons learned, but since I have only 10 minutes, so I will share a couple of examples of important lessons learned with our international colleagues. Yeah. So the most difficult period to confront COVID-19 is the big wave of infection like this. So here we are looking at the daily new cases per million people since early March 2020. And this figure includes Japan, Vietnam, Thailand, Kenya, and the UK as an example of high-income countries. So as is shown here, the UK had a huge surge in the winter 2020, and this wave is also happening now again here. And other countries had relatively mild waves up until the summer 2021. However, because of the Delta variant, the big surge occurred in 4 countries. And during the surge, we need to provide care for many infected patients, and we also need to maintain certain acute medical care services. And this is the same data as previously one, but exclude the UK to see more detailed differences in the 4 countries. In Japan, as you see, with this blue line, like this, we have a peak of patients in August 2021, and we had a really difficult time during this surge, especially in Tokyo, and it was kind of kind of disaster. And during this period, of course, people worried about the impact on societies and their lives, and there are many patients who suffer from diseases other than COVID-19. For example, surgeries were canceled or postponed. And if we look at the data in Thailand and Vietnam, like this, so I can imagine how hard it was for people and healthcare workers, since the wave was much bigger than that of Japan. This is a news article reporting the situation in Tokyo on the 5th of August, 2021. And during this period, we might say that our medical care almost collapsed. So however, there was a huge criticism of why Japanese healthcare systems collapsed so easily, even from a wave that was very small compared to that of other countries, especially like G7 countries. And this slide shows the number of patients that needed intensive care due to COVID-19 in Japan since March 2019. And as you can see, there are kind of 5 waves. And every time, of course, we try to enhance the capacities to strengthen our response to the surge. And this figure shows how we work to ensure the capacities of patient care from the October 2020 to January 2021. And the capacities were multiplied by almost 5 times in 3 months. And in Japan, many private hospitals in the yellow one, also follow the same payment scheme of national insurance. And some private hospitals were hesitant to accept patients with COVID-19, even though there were certain incentives for private hospitals. But gradually, more private hospitals have been committed to the COVID-19 response. And there were some direct incentives for healthcare workers from the government for nurses and doctors and some other staff. The securing healthcare pathways and management systems would be essential. So in Japan, patient first call to primary care center, which is the clinic or doctor's office. And they go to here and get the testing. And that if the test was positive, that the doctors write a report and then send it to the public health center. And there are 400, 500 public health centers in Japan in 47 prefectures. And also in prefecture level, they have the oversight and the coordination mechanisms for especially for the severe patients. And if the patient who got a positive result usually stay at home as a home isolation, or they may be transferred to intermediate facility, which has been used as a kind of the hotel for staying for several days. And some patients who have very severe conditions are going to the designated hospitals. And public health centers in communities collect detailed information about patients from this clinic. And they also proactively communicate with individual patients. So as you can see, the OECD report, and this is also the Sakamoto-san also showed, but the number of hospitals in Japan is higher than in other OECD countries. Here is in Japan, it's a blue one, the orange one. And this is the, I think it's the average of the OECD countries. And yes, but because the number is large, but mostly are composed of the long-term care. And doctors and nurses, the number is here, 2.5 per 1,000 and 11.8 per 1,000 population in Japan. And these are almost average number of the OECD countries, and a little lower and a little larger than OECD average. So during the surge, some parts of the acute care capacities need to be allocated to COVID-19 in exchange for essential health services. So, but we may need to discuss how to maintain a reasonable balance of allocating the resources for COVID-19 and other diseases. And long-term capacities can be mobilized to care for patients with mild symptoms of COVID-19. And in communities, there are resources that can be transformed to COVID-19 care through education and training for healthcare workers, and also with financial incentives. So now I can share the issues what we need to tackle, and limited capacities for providing adequate care to all patients during the surge period, and less than expected COVID-19 response efforts from public hospitals. Financial incentives need to mobilize private hospitals for the care of infected patients. Lack of leadership and coordination by the local governments. Lack of law enforcement that require hospitals to comply with the government's request during the critical period. And lack of healthcare workers who are trained in infectious diseases. So we are working for these issues. So what I would like to emphasize is that we healthcare workers knew what services would be necessary for patients. But the problem is that it would be difficult to designate who will do actual work, and also who will pay for it and how much it would cost. So even though we have very good system in usual time, but we need to additional settlements or coordination among healthcare resources and stakeholders. And to prepare for another wave, maybe possibly coming as a sixth wave, local prefectural governments are now required to have a concrete plan that will work during the surge based on the request by the Japanese government and the strong leadership by our new Prime Minister Kishida. So in the end, I share this slide, and what we can see is how steep the vaccination coverage increase in Japan. This is Japan. And also the Thailand and Vietnam also has very steep line for covering as many as people. And Kenya is also going to catch up. So the key to success of vaccine rollout is trust among people for healthcare and also the government. And now we still have been great momentum for sharing the value of universal health coverage and our achievements in the future. And that's all from me. Thank you very much.
Thank you very much, Professor Wada, for sharing the very key lessons and important facts from Japan's experience. I'm sorry that we are asking you to keep 10 minutes. Maybe next time we'd like to listen more or in the panel discussion. And next, I would like to ask Professor Margaret Kasege, Director Program and Research the Tropical Institute of Community Health and Development Trust, Kenya, sharing the Kenya's experience. She is the expert on the community health in Africa. So, Professor Margaret, can you hear me?
Yes, I can hear you. Thank you.
Yes. Okay. So please share your experience. Thank you.
Thank you very much. Good afternoon, good evening, good morning to everybody else. Sorry for this, but I thought the slide is going to be shared from the other end. Let me just see if I can.
Professor Margaret, please wait for a while.
Yes. While we're waiting, I want to thank Professor Wada Koji. You're saying that Kenya is going to catch up with vaccination. I do hope so. I hope so.
Okay, the presentation is on the screen.
Thank you so much. So I'm going to share with participants the situation of Kenya and how we tried to address the issue of COVID-19 within our health system, which is an example of a resource-constrained setting and what we did to just mitigate the pandemic in our situation. Next slide. Sorry, can we have the next slide? Yes, so globally, the situation is that 260 million cases of COVID-19 now exist in the world, according to WHO 2021. For Kenya, we're about a third of confirmed cases as of this month, with 5,000 deaths, and also about a third of recoveries. As of May 2021, Kenya had contributed 0.1% of cases, death and recoveries globally. And as you have seen from the previous presentation, Kenya is way down in terms of comparison of the number of cases of COVID-19. So what did Kenya do to mitigate the situation? We took a preventive measure. So in early 2020, when the COVID-19 was announced, the Ministry of Health encouraged a social and preventive approach. This consisted of social distancing, wearing masks, and hand washing. And this practice is still continuing even as we speak, even as we look at the new variant, which is coming on us. Again, the government sent out directives for each of the divisions in the country. These are counties. We have 47 counties. And the directives was to prepare isolation beds, ventilators, to make sure that they had oxygen capacity, and to train the workers to be able to take care of any patient that was reporting. It was left for each facility and each county to develop their own specific plans for continuing services. Because in our setting, each county has different capacities. So there was no one standard of requirements, but each one was to come up with preventive measures based on their capacity. Now, the health sector got increased funding during this COVID period, and this one was from the government as well as donors. The World Bank contributed to some of these expenses. In addition to these preventive measures, the country came down with lockdown. There was curfews, and of course, then people were restricted in institutions. So some of the institutions, the major institutions, were closed. Next slide. Can I have the next slide, please? Yes, so some of the key actions that were taken during the first 3 months of the pandemic in Kenya, and this happened in March 2020, when the country declared that COVID-19 was in the country. A ministry set up a national response and emergency committee, and this one was launched in order to give direction to the country in terms of prevention and some of the measures that were required to stop the COVID-19. In addition, there were some directives on case management, infection prevention, and we focused a lot on home-based care because quickly we realized as a country that we just did not have enough beds to take care of patients who needed them. So the country identified specific health facilities that were able to manage COVID-19 across the country. There was increased surveillance, laboratory services were revved up, and then the ports of entry into the country from the regions and other countries were tightened up. So anybody coming in was monitored, as well as health information. There was daily reporting of COVID-19 cases, and this one generated a lot of demand for daily statistics. For instance, every day it was announced how many people had been tested, how many were positive, how many were hospitalized, and so on. And this kind of information kept the people well aware of what the issue was, and it was mainly it was given over radio and over television. And in a way, this was like an intervention to keep the people aware of what the situation was. Next one. So here you can see the graph quickly rising up as of March 2020. As the cases began to increase, the government realized that it needed to provide some kind of guideline to make sure that any services that were being offered was complying to standards. Next one. So some of the guidelines that were produced, these were interim guidelines because there was no legislative procedures at this time. So guidelines were produced to help the services to continue. So for instance, very quickly, the government produced guidelines on human resource for health, the health workers. How were they going to be distributed within the different facilities? What about the services, other services like nutrition, like for non-communicable diseases, like community interventions, home-based care? What about people with HIV? What about counseling to those who are coming into the facilities, and even counseling to the health providers? What about infection prevention and control for COVID-19? So this was an intervention, providing guidelines that would be readily available, that could guide people on what to do. The next one. So for instance, human resource guidelines, I won't go into the details, but it looked at management, how to plan the shifts, the work shifts for the health workers. What about fatigue? What about burnout? What kind of equipment did they need? Personal protective equipment. What about the training, the skills that they needed? And what numbers were required for the health facilities at the different levels. So these were like emergency kind of measures, providing these guidelines to help the health workers and to help the country to move forward. Next slide.
Dr. Margaret, your voice is a little bit small.
Yes.
The volume is small. Yeah. Can you? Now it's okay. Yes.
All right. So one of the areas was training and capacity building for health workers. So as I mentioned before, we targeted what the gap was. The gap was management for COVID-19, preventing infection, using PPEs. How do we engage communities? What were the risks for community workers and also for the health workers? What kind of surveillance was needed? So these were some of the areas that the country targeted very quickly. Remember, we didn't have much resources, and even the donor that was given was to target very specific areas that needed to be addressed. Next one. So one of the things that we did was the community engagement. In all the counties in the country, we have community health workers. So we engage them very quickly to go to the households, to talk to the members of the households for prevention, to give out messages, to guide women and children who needed to get health services to continue going to the health facilities. So this intervention was very, very targeted. And it came in very useful, for instance, when we started having patients who were being cared in homes. It's the community health workers now who did the visits, of course, taking care of themselves, making sure that they had face masks, gloves, and sanitization, and making some of the contacts using their phones. Supervision also was largely through phone contacts. Next one. So this approach is one that I think other countries can take on during emergency or during normal services, where you train volunteers to go to households, to refer, to encourage use of facilities for deliveries, and to give out messages that are very appropriate to the population in a way that the people can understand. Next. So here is one of the things that the country also did, monitoring. Were people really taking preventive measures? And this is just one example of the monitoring that took place. So for instance, here you can see that most of the information on COVID-19 was obtained from radio. So knowing that, one could target radio to come up with messages that would continue encouraging preventive measures. The next source of information was CHV, community health volunteers. Again, one could use community health volunteers to keep encouraging preventive measures, even as we tried to address the increasing infections. Continue. So where are we right now? Of course, compared to other countries, we are still way down. Our positivity rate is at 1.6%. If you look at the right-hand side, COVID-19 update, the cases are few. And in some of the counties, there's only one case, one or two cases. So it seems like our approach has kind of helped us to mitigate the COVID-19, just doing a very intensive community household outreach with preventive measures. Next slide. Now, of course, you may wonder, what about vaccination? Yes, we have received 20 million vaccines so far. And as we are continuing, one of the services enables people to just register to know where the vaccination facilities are. So at this point, we're about 11% of the population that has been vaccinated, way below some of the more developed countries, but we are catching up. Next. So learning from COVID, what are some of the approaches? Coordination, very important, whether it is from the global level or from the national level, training and getting all the stakeholders to come together to address the COVID-19. Of course, health workers, training them, helping them to know what needs to be done, having an information system that is monitoring issues, identifying capacities, planning, infrastructure. All of these issues, I think, are things that we have learned in COVID-19. And for a robust health system, we need to have these things in place, whether we are in normal service provision or whether we are in an emergency or a pandemic situation. Thank you.
Professor Margaret, thank you very much for sharing the precious lessons from Kenya that focusing on community health importance and the human resource and so on. Okay. Next, I'd like to invite Vietnam, Dr. Tran Thi Mai Oanh. My pronunciation is all right. I'm not sure. Yes.
Correct.
Yeah, okay. Director, Health Strategy and Policy Institute, Ministry of Health, Vietnam. The Vietnam is known as very successful country in the first period, but experienced the rapid increase of COVID-19. So it is very valuable to learn from you. So, Dr. Tran Thi Mai Oanh, the floor is yours.
Thank you very much, and good evening, everyone. Firstly, I would like to thank you for giving me the opportunity to share with you on the case of Vietnam regarding the health service delivery system from the experience of COVID-19. So next slide, please. So the first slide, I would like to share with you about the COVID situation in Vietnam. So as you already mentioned that we have 4 waves of COVID-19 in our countries. From the beginning, we are very successful in preventing and controlling COVID-19. But from April this year, we have to face with the 4th wave of COVID-19, which the number of cases, COVID-19 cases, increasing very fast. So at the current, at these times, the total number of cases COVID-19 is more than 1,300,000 infected COVID cases. And with the death rate is about 2%, and the recovery rate about 75.6%. So at the moment, we are still in the 4th wave of COVID-19, but I would like to say that now at the current times, we are in the stage of controlling the COVID-19. So next slide, please. In this slide, I would like to share with you on the overall picture of health service delivery system in our countries. So you can see in the slides that regarding to the public sectors, we have the 4 levels of care, of which at the lowest level, it is at common levels. We have the wide networks of common health stations. And then after that, for the 2nd level, it is district level. We have the district health center. And the 3rd level is the provincial hospital. And in the highest level, it is the central hospitals. So the grassroots healthcare system includes the district health center and the common health stations. And together with the public sector, you also see that we have the a big number of the private sectors, including the more than 200 private hospitals, and with huge number of private clinics and private pharmacies. So next slide, please. So in terms of the COVID-19 treatment, you can see that we organize the health service delivery system into 3 tiers of COVID-19 treatment. So you can please you can look at on the slide that with the 3 tiers, the tier 1, it is the lowest level, including the common health station. So common health station is responsible for treatment of COVID-19 cases with mild or no symptoms. So the patient with mild symptoms or no symptoms, they are treated at home. And for the tier 2, Tier 2 is including provincial hospital and district hospital. They are responsible for treatment of COVID-19 patients with moderate, severe symptoms. And at the Tier 3, it is the highest level of treatment for COVID-19. It is the tertiary hospitals, including the central hospital. They are responsible for treatments of the COVID-19 cases with severe symptoms. So the patients who are treated at home at the Tier 1, when they are classified as more severe symptoms, then they will be transferred to the higher tier. So normally they will be transferred to the Tier 2 at the provincial hospital or central hospitals. And when they are treated and they can be recovered from the COVID-19, when the testing COVID-19 is negative, then they will be transferred back to the commune level to be followed up by the commune health station. So next slide, please. Yes. So in this slide, I would like to share with you on the solutions that have been done to strengthen the capacity of health facility in each tiers. At the Tier 1, the lowest level, where we manage and provide treatment for about 80% of the COVID-19 cases. So we applied many different solutions to strengthen the capacity of the commune health station in providing treatment for the COVID-19 patient, including together with the existing commune health station, we established the voluntary mobile team. We call that is mobile commune health station to support the commune health station, the existing commune health station. So the voluntary mobile team will be responsible for monitoring the COVID-19 patient at home. And for this team, we also mobilized the private sector, private healthcare provider to participate in the mobile team at the commune level. And at this level, we also provided training for commune health workers, and also the mobile team know how to monitor and manage and provide medicine and follow up the COVID-19 patient at home. And also we provide the oxygen and medicine for the commune health station for the case for the case if the patient become more severe, so that they can have the oxygen and also medicine to treat them right at home. Ministry of Health also provide technical guidelines, very concrete guidelines for the commune health station to guide them how to monitor, how to follow up and treat, provide treatment for the COVID-19 patient. And at this level, for those who have the NCD symptoms, NCD disease, in the case if they need the technical assistance from the higher level, so remote consultation from the hospital at higher level will be made. If the commune health station they request for technical support from the health facility at higher levels. So similarity to the Tier 2. Tier 2 here is provincial hospital and district hospital. We also have the strategy to strengthen capacity of number of beds for COVID-19 treatment. So we reorganize the health facility at the province level to be responsible for COVID-19 treatment and training the health workforce for the ICU. Because at this Tier 2, it provide treatment for the moderate and also a number of severe cases at this level. So training for the doctor and nurses on the ICU it is also provided for this level. Invest in providing equipment and oxygen, as well as providing remote consultation from the higher level, also made for the health facility at this level. At Tier 3, for the Tier 3, as I mentioned, Tier 3 will provide treatment for severe cases. So the number of existing tertiary hospitals are not adequate. So in the fourth wave, when the pandemic becomes severe, we also established the temporary hospital for treatment of severe COVID-19 cases. And also we reorganize hospital for COVID-19 cases at the moment. It means that for the existing hospital at the tertiary level, we use this hospital for treatment of all COVID-19 cases, and together with the temporary hospital. So we provide the services for the severe cases at this level, and also increasing the number of ICU beds at the tertiary care level. So we implement different strategy, different solutions to strengthen the capacity of health facility at the different level in treatment for the COVID-19 patients. So next slide, please. In this slide, I would like to share with you on what are solutions to increase accessibility of non-COVID patients to healthcare services, because during the COVID pandemics, the patient who suffer from non-communicable disease, they don't want to come to the health facility to receive the services. And also with the other patients, another patient who have suffered from another type of disease, we don't want them to come to the hospital at the high levels. So we introduce the telehealth services in which the health facility at the higher levels support the health facility at lower level in diagnosis and treatment of the patient at the lower levels. And at the community health station, because we introduced a treatment for the NCD patient at the common level at the community health station. So before we provide medicine for the NCD like hypertension for 1 month, but during the COVID-19, we ask the community health station to provide medicine for the hypertension patient with the medicine for the 3 months. So we extend the times of providing medicine for the hypertension patient longer, so that they don't have to come to the community station monthly to receive the medicine. So we introduced telehealth services for the reducing reference patient to central hospital, and also providing more medicine at the community health station to increase the accessibility and utilization of services for non-COVID patients at the grassroots level. So next slide, please. Yes. So for this slide, I would like to share with you on the advantage of why the advantage or the strengths of our healthcare system in providing the services for the COVID-19 patient. The first one is that we have very high commitment and determination of the country leaders, in which the National Steering Committee for COVID-19 Control has been established at the early stage with the decisive actions with a multi-sectorial response plan. And the second thing is that we have the early policy and response planning, in which the guideline was consistently updated throughout the pandemic. And we also have the robust disaster contingency plans and protocol to disease with the 5 scenarios for the COVID-19 pandemics based on the different number of estimated COVID-19 cases, and in which we identify resources needs for each scenario to prepare for when the number of cases of the COVID-19 increasing. So we identify the needed resources and identify the gaps in terms of resources to make the plan to prepare for prepare for the solution to deal with the different number of the COVID-19. Another strength is that we have a wide health services delivery network, a 3 level of care, as you already hear from me from the beginning. But I would like to mention that the central hospital in Vietnam have been under the management of Ministry of Health. So during the COVID-19, we see very clearly the role of Ministry of Health in coordinating and reorganizing the health facility at the Tier 3 to support the provinces in treatment of the COVID-19 for severe cases. And we also have a wide network of community health stations. So they are responsible for treatment and management of about 80% of infected COVID-19 patients who have mild symptom or no symptom at home. So next slide, please. Yeah, in this slide, I would like to point out a number of challenges in preventing COVID-19. The first one is manpower of the health system. We have a problem of shortage of healthcare providers in most of health facility at all level, and a low proportion of nurses per doctor, because you see that for the COVID-19 treatment, it requires the comprehensive care. So it is a challenges of us in terms of this. And the second thing is that the number of professionals in terms of doctor and emergency nurses for treating the severe cases in the ICU. We lack of these ICU, the doctor and nurses who are trained in the emergency backgrounds. And we have the limited capacity of healthcare workers at the grassroots health facility, particularly at the community health station. The second challenge is that the financing in preventing COVID-19 pandemic. Even we have the many policy and strategy to mobilize resources, financial resources for preventing the COVID-19. But we still want to point out that we still need to increase the budget for preventing and containing the COVID-19. And the biggest challenges is how to ensure adequate financial resources for vaccination for the Vietnam population. And the last challenge is that I would like to say here is that the challenge is for keeping the vulnerable population safe, especially for the non-communicable patient. So how to ensure the sustainable health service delivery system with better responsiveness to provide healthcare services for the group of NCD patient is important, and we need to strengthen in the coming times. Yes. So next slide, please. This is the final slide. In this final slide, I would like to have some point out some key lessons learned that make Vietnam to be a success. And at the last 3 waves of the COVID, and even in the 4th wave of the COVID-19 prevention, we are still able to respond for the COVID-19. We have the 3 main lessons. Is that the first one is that the commitment and the determination of the country leaders is very important to make the pandemic prevention become success, especially the collaboration between the central and local government is a key point. And the second thing is that the engagement of the entire political system and multi-stakeholder participation is very important. And The last point is that grassroots healthcare service delivery system play a very important role in healthcare for NCD and COVID-19 patients. So I finished my presentation and I would like to discuss more with you during the discussion. So thank you very much.
Thank you, Tranchi Mayon. It is very comprehensive, and it includes a very key important lessons from Vietnam. Thank you very much. So I'd like to invite Dr. Walaipom Pachalanumo. I'm sorry that I cannot pronounce very well. A Director of Global Health Division, Ministry of Public Health, Thailand, sharing Thailand experience. Dr. Walaipom?
Yes, Ka, I'm here.
Yes, yeah, we can hear you. So floor is yours.
Thank you, Ka. First of all, สวัสดีค่ะ greeting you from Thailand. Next slide, please. This slide show you that in Thailand, we monitor not only the COVID-19 situation in Thailand, but also the worldwide in order to update ourselves with the COVID situation. I will not go in the detail because panelists already spoke on this data. Next slide,ค่ะ. For the next slide, show the Thailand situation. Nowadays, we have around 3,000 or 4,000 new cases. Fortunately, the death rate decreased sharply. Previously, we have many deaths, but nowadays, because of the vaccine, as Professor Wadat mentioned, the coverage of the vaccine at this moment is around nearly 70% of the population. That's why the death rate in Thailand is quite low. And we monitor the Omicron, how severe it will be. The Omicron is in the high concern. At this moment, we found 5 cases in Thailand already. Next slide,ค่ะ. For this slide, if we using the lens of health system 6 building blocks, for each component for the leadership and governance, yes, of course, similar to many other countries, in Thailand, we established Center for COVID-19 Situation Administration. This is chaired by the Prime Minister, and then many measures outside health sector were applied. For the health workforce, as many countries concerned, this is the situation in Thailand. We have limited number of physician nurses, but fortunately we have epidemiologists. We have the field of epidemiologist training program for more than 4 decades. It made Thailand has some epidemiologists. It is around 0.5 per 200,000 population. It's still far away from our target. We would like to have at least 1 epidemiologist per 200,000. For the medical products and technologies, this is no problem because we have a quite good system for that. For the financing, the government announced free for all. It means that free for prevention, diagnosis, lab treatment, even for the quarantine for all infected cases. This is not limited only for Thai people, but also for non-Thai people as well. Because we know that for the COVID-19, we are not safe until everyone is safe. For information, at the beginning, it's chaos, really chaos. I guess that we experience on the chaotic of information in many countries, in Thailand as well, really chaotic. This might be biggest challenge that we need to explore and invest more on information. For the service delivery, I will show you in the next slide that we have a comprehensive service delivery similar to Vietnam. Next slide, please. For the service delivery, as you know that Thailand has achieved universal health coverage since 2001 and 2002. So 100% of the Thai population is covered by either one of the three public health insurance schemes. Good luck for Thailand that we have 100 geographical coverage of the health facility. On the photo on left-hand side, you can see tertiary care, secondary care, and primary care throughout the country. And similar to Vietnam by Dr. Mai Wang, on the cascade of the service delivery from community level, primary care level, secondary, tertiary, until excellence center. Majority of health service delivery in Thailand are from public sector. We have private sector. Its capacity is around 15% of total beds in Thailand, hospital beds. Another thing that I would like to point out is the 1 million village health volunteers. 1 million village health volunteer is at community level. They are eyes and ears for us to scrutinize every citizen in their village. And then this is very effective for COVID prevention. Another bullet point at the bottom of this slide is on field of epidemiology training program, as I mentioned to you earlier. And also the SRRT, the surveillance and rapid team response team. This is very good that we have until it at the district level, and then they are at the primary care level. Next slide. This slide shows you about the financing. My issue focus more or less on financing, because we know that service delivery needs money to support. The government announced that all expenses of essential health services related to COVID-19 will be fully covered by Thai UHC, not only for Thai people, but also for non-Thai people. This is guaranteed by the government since the beginning, and the management is not difficult because we have the Thai UHC, and then we apply the financial management similar to the UHC in Thailand, and then we can ensure free COVID-19 screening, testing, quarantine, treatment, medical supply, as well as home and community isolation. It is managed through Ministry of Public Health and all the health insurance schemes. Next slide. For the management of the major scheme in Thailand is by National Health Security Office, because they cover 80% of the population. We have annual budget. Look at the bottom of the slide. The annual budget will take very long time. Its process is around 2 years in advance. We can also get the approval to use the annual budget through the Community Health Fund for public awareness, prevention, and health promotion at the community level to support village health volunteer. But for COVID-19 itself, it is an additional budget that we need approval by the cabinet. The COVID-19, as I mentioned earlier, it covers very comprehensive benefit package. Next slide. Next slide will show, this slide will show you the expenditure that got approval from the cabinet 4 times already, and we still need to get additional budget for the next fiscal year. It is huge amount of money that Thailand invests in tracking the COVID-19 in beating the COVID-19. This additional budget ensure that we have adequate financial resources to fight with COVID, but our next generation, our children, will need to bear the cost of the COVID-19 because some of the budget are from loan, and then we need to pay back in the future. At the same time, economic of the Thai society drop similar to other country. This is the burden. We have more expenditure, but we get less revenue. This will be in our future that we need to tackle. This is quite worrisome for the Thai people. Next slide,ค่ะ. But anyway, we still need to beat the COVID-19. As mentioned to you earlier, the COVID-19 services, related health services, cover general population for vaccination. For people at risk of exposure or the PUI of the COVID-19, and for the COVID-19 patients who are infected, as well as who got the adverse event or adverse effect from the COVID-19 vaccine as well. Due to the time limitation, I cannot go into the detail, but in general, I would like to give you the overview that all health services related to the COVID-19 are free in Thailand. Next slide,ค่ะ. For this slide, lesson learned that we get from the COVID-19. First thing first, we see that the whole of government and whole of society approach must be applied, and it is applied by the COVID-19. This might be the disruption for the government and for the whole country. Private and public health facility need to work together very well, including the society and the community level. Everyone, we need effort and collective effort by everyone. Then come to the second bullet on coordination and management. We need to manage and coordinate very well. For the new normal, we need to adjust our life, both routine life, because we need to keep distancing. The shopping mall shut down some days, nearly months. We cannot go out freely as usual as we can in the past year. The working style, we need to change our life of the working from home. Even during the meeting here, we still have online meeting and we need to meet virtually. For the health services, we still need to adjust for the new normal as well. Another thing is the digital disruption. We need to use the AI or telemedicine to support our work. We see clearly the importance of health promotion and disease prevention. Next slide. For the way forward, we still need to live with COVID-19. And at this moment, Omicron is coming to many countries. And then we need to adjust ourselves again to the COVID-19. For the health workforce, we see that mental health of healthcare workers is very important. We need to support them on this issue. At this moment, we already support them, but we see that our health workforce feel fatigued on fighting with the COVID-19. And glad to learn from many other countries on many issues that you boost the health workforce. The presentation by Haruka is very useful. For the medical supply, we need to invest more in drug and vaccine, especially the COVID-19 research. Financing, as I mentioned, is free for all, and it is the burden for the country, and it will be not only our generation, but also our children as well. Information, we think that this is the most painful component in Thailand. Interoperability similarity among many sources of data need to be linked together for better usefulness of the information for policy decision. For health service delivery, I see that Thailand can modify ourselves very well. For example, we have burden with the hospital and then we do the home isolation that is workable and it is functioning very well. These are the experience from Thailand. Next slide that I would like to share with you. And then if you need more information, you can follow us. Thank you very much.
Dr. Walaipon, thank you very much for a comprehensive presentation. The whole government approach and the health system perspectives. Okay, so dear participants, I think you got a lot of information from various aspects. So it might be difficult to digest, but from now on, I would like to ask. I approach it that my time management is poor, and we are running out of time. But we'd like to extend our time 10 minutes and have some discussions. The next, I'd like to invite Professor Tomohiko Sugishita, Professor of Tokyo Women's Medical University, to moderate the panel discussions.
Thank you very much, Saida-san. Very exciting. And this is a real community of practice and also learning opportunity for all of us and all the participants. And also I want to also stress, but this is the health systems, how unique. And also this is very reflected by your own history, also demographic, and epidemiological transition. So each country has different health systems. However, we have to tackle with pandemic. So our mission is really same for us in our passion. Especially Haruka pointed out the importance of service delivery and its flexible health systems. Also, Koji is really from Japanese experience. He told us about surge capacity, how we can build the preparation of the surge capacity within the health systems. Also, Margaret it's always African context and also community engagement and also especially their leadership in the community. So that is a really important aspect of health systems. Also, Tran, you also mentioned about the referral systems and human resource development. So this is a real part of the health systems. And Walaipon-san, you are talking about UHC, universal health coverage, and especially also health insurance scheme and stewardship of the government. So that is a really important aspect of the health systems. I will ask Saida-san to pick up, or we have already have many questions and also inquiries. So you can select several questions. Before that, I want to ask all the panels about the most critical part of the health systems. I will ask Koji, Margaret, Tran, and Walaipon that what is the most critical factor to hinder your health system transformation during the pandemic? Especially pay attention to the as a surge capacity. What is the problem in your country? Most biggest challenge, and that is a lesson to other countries. And also ask lastly, Haruka, also from your survey, please let us know about how G7's lessons that are mostly affected by pandemic during how the most critical hindering point of the health systems. So first of all, Koji, tell us about your thoughts.
Thank you very much. So in Japan, as I also talked during my presentation, the local government, actually there were 47 prefectures in Japan. Like prefectures are kind of the administrative divisions, same as the provinces or states. And each prefectures have a governor, and the governors are politicians and elected by the election. And usually not the medical doctors or healthcare workers, they are politicians. So he has a leadership for also preparing for the healthcare systems for the COVID-19 patients. And there are some different gaps among the local governments, how they are preparing for the beds or health systems or access to the testing. And of course, it won't be easy. It's very difficult to imagine and estimate how many beds are needed during the surge, because the surge is a kind of the it's very difficult to estimate how many patients we are going to have in 2 weeks after, or even after 3 weeks. So yeah, lack of the kind of leadership and coordination was not really good in the really early times, but we have the 5 waves, and now by the leadership of the government and also the prime minister, we have the very concrete objective or target, how many beds we should prepare and how it works. And now it's getting better right now, but still sometimes it's not easy for governors and also governors to prepare for the surge of this pandemic. And I would like to say one more thing, that is the for the government or level. But another thing maybe I can say is kind of for healthcare workers, kind of the sectionalism. If I can say, for example, there are so many infectious disease doctors who are really worked for a long time, during the surge, but some other specialists like orthopedicians, ophthalmologists, they may have time and not too busy but not committed with the COVID-19 response. But of course, it's also depending on the head of the hospitals or CEO of the hospital, if they have the great leadership, and those other specialists are also going to commit with the COVID-19 response. But we need young doctors, even for the senior doctors, to understand how they can contribute to this pandemic or very kind of disasters. So that's the things which we need to tackle for next year, for next coming years. Thank you so much.
Very interesting. Thank you very much. How about Margaret?
Thank you. I think one of the real big challenges is having enough funding for the health sector, because usually it takes a crisis like COVID-19 for the system to realize that the sector is bleeding, it's not getting enough funding. And I know there have been declarations. If we look way back to the Abuja declaration, it said 15% of the budget of the country should go to health financing. I don't think we've ever reached there. We are just halfway. So of course, it's going to affect human resource. It's going to affect the infrastructure, the equipment, the health products. I think that is one of the things that, if not addressed, the health system will always be lagging behind. Thank you.
Thank you, Margaret. How about Tran? Your thoughts?
Okay. So, the most challenges in Vietnam, it is the human resources. Because during the pandemic, we see that we have a problem of shortage of human resources. And after the pandemic, we also see a big challenges in terms of the human resources, is that how to maintain them, to continue working in the health facility. Because there is a problem of like Walapon mentioned, after the pandemic, many of them are scared and also feeling stressed in the situation of low salary. So many of them want to stop working in the health facility. So it is the most challenges for us. It is the human resources. Thank you.
Very interesting. How about the Walaipong?
Yes, Kat. Many others mentioned, which I agree. Health financing is also really important, even though in Thailand we have quite sufficient financial resource, but we are worried about the future because we are in debt and we need to pay back in the near future. That is worrisome. But the main challenge, in my view, is on information. Even though we passed 2 years already, but the information is not getting better enough. It is better, but I think it can be better and better. We must use the health data, for example, the vaccine. We need the vaccine certificate in order to travel around. We need the Thailand pass or EU pass in order to travel between continents. And then the kind of information that we need to put in and exchange between country or even within a country is very important. And then in the previous years, we still inadequate invest in health information system. And then I think this is one of the most challenges in Thailand. Thank you.
Thank you very much. Rastri Haruka, your lessons from G7?
Okay, thank you very much. I think there's a 2 points. One is the lack of the sense of urgency, and then the lack of sense of urgency, and then the lack of the preparedness. So first is about, particularly in the case of high-income countries such as G7, I think there was a sense that they would be fine if pandemic comes. And then they thought they would be able to cope with the pandemic even if it comes, but the reality is not. So that is kind of the not accurate sense of confidence can obscure the challenges facing each country faces. And then lack of the preparedness is because the high-income countries has not experienced the major pandemic in the past decades. On the other hand, most of the Asian and African countries experience a lot about the pandemic, so they know the reality of the pandemics. On the other hand, high-income countries does not have the reality, what it looks like. So the sense of urgency and then the sense of the lack of the sense of urgency and the lack of the preparedness and the experience is the key for the high-income countries, I think.
Yes, indeed, age of SDGs. And we have to think about the planet consciousness, including all the countries have to tackle with pandemic. Otherwise, it will continue to end of our human history. How about Saeda-san? Time flies like an arrow, but can you tell us about some questions from important questions from the floor?
Okay, thank you very much. There are a lot of questions from the floor. There are some questions about disparity in access to health services has changed before and after COVID. I think there's maybe private sector engagement or remote consultation introduced, data monitoring system widely applied in countries, and it may change some improvement or some change in access to health services. That is one issue. And another interesting question is about remote consultation introduction. How have you prepared remote consultation in countries? Already it was prepared before COVID or during COVID? Such questions we got. Maybe we don't have a time, so maybe we can pick up one and ask somebody.
Yes, I will try to combine into one. Actually, we have to have equity lens to see the health systems, and then how your country to tackle with those equity issues during pandemic, using some technologies or using the new human resources, new ideas. So tell us about how you can mitigate those equity gap within health systems during the pandemic. So I think starting from Walaipong-san, the other way around. Okay, Walaipong-san, tell us Is there any challenge or some lessons those equity, runs in health systems?
I see this is a good opportunity. Previously, we have a problem of non-Thai people who are not covered by Thai UHC. But when COVID comes, it is really great that the government concerned and pay for them all, regardless of the nationality. I see this is a good opportunity of the COVID-19 provide to us, and then it will widen equity lens to the government to provide more. And I guess that it will continue after COVID-19, and I hope. Thank you.
Yeah, during your presentation also you told us about the issue of those, non-habitants, non-national, communities. Thank you very much. How about Toran-san? What is the challenge in equity?
Yes, you ask me. Yeah. Yes, in Vietnam, regarding to the equity issue, because the issue is that we need to increase the availability of services for the people where they need. So it means that, like in our country, we tried to increase the availability of services at the grassroots level. So when I mentioned, like in my presentation, I mentioned about the remote consultation. It means that we increase the availability, the capacity of health facility at the lower level to ensure the availability of services. And also we increase accessibility of the patient at this grassroots level, so that they don't have to be referred to the higher levels. So for the question that one of the participants raised the issue of remote consultation, it is prepared before or after the pandemic. Like in Vietnam, we introduce this intervention before the pandemic, because we want to support the health facility at the lower level, so that the remote consultation are made. But the COVID will be a good opportunity that we increase the application of remote consultation for the health facility at the lower level. Yeah, so thank you.
Yeah, very interesting. The changing landscape for digital transformation to hinder, to improve the equity gap. Thank you very much. How about Margaret? How about the equity issue in Kenya?
Yes, I think what is really interesting is technology. The community health workers were able to get information about their households using the phone, the telephone, the handheld telephone. And I think that has changed information sharing, knowing which facility to go to, which facility had oxygen so that they could refer the patients, just because of the information flow that was so easy on their phones. So I think technology disrupted the usual information sharing and enabled people to be more engaged with what the issues were.
Very interesting. E-insurance system, MTIBA, and other, trial for the, digital transformation. That is great. And also, Koji Sensei, how about Japan?
Yes, I'd like to share the example of equity issue in Japan for the vaccination distribution. So during the vaccination rollout, we prioritize healthcare workers and the elderly, but some of the local government prioritize like people who are working in the food industry or restaurant and bars, and also some foreigners resident in Japan. So those people are really usually vulnerable groups, and they may have the lack of the access to the vaccination, but some of the municipalities have determined to prioritize those population group. That was really good challenges, and yeah, that is really good example for the equity in Japan.
very interesting. Also, it's up to the governor's stewardship. But that you are also critical points to hinder Japanese healthcare system. Thank you very much. Haruka, do you have any lessons from G7?
Okay, thank you, Sugishita Sensei. Actually, those are not specific lessons for the G7 countries, but when I'm looking back to answers from the G7 countries, I think there's no way to do some policies for the vulnerable population in crisis time, what has not been done in normal times. So I think it is important to know how to implement fair and equitable policies for vulnerable population in the normal time. So if we cannot provide healthcare services, quality, equal healthcare services in the normal time, we cannot provide equitable access during the crisis.
Thank you very much. Indeed, no time now. So I want to listen more and more eternally, actually, from also not only for countries, but also your countries in the participants, how you can tackle with the pandemic, and also all the lessons to to build the resilience of our health systems. I think thank you very much for all the panelists and also all the participants. And my mic back to Saida-san. Thank you very much for the discussion.
Thank you very much, Dr. Sugishita, for moderating the panel discussion. Okay, so I'm very sorry that we used 15 minutes more for the webinar, but we learned a really lot of fruitful or valuable information, experience from speakers. Okay, so thank you very much for all the speakers and all the participants. On December 12th is the International UHC Day. So we are facing difficulty in COVID-19, but it is very important for us to think about UHC and how to make our health system more resilient towards achieving UHC. I hope this webinar could benefit to you to think about such a thing. And JICA is committed to achieve universal health coverage. So we'd like to work with you and learning from each country to achieve UHC. Okay. So I would like to close today's webinar. And again, thank you very much for everybody to participate for a very long meeting. See you next time.